available in our hospital. Then we verified the data on a cross-sectional study. It was done in Al Mawasat University Hospital in Damascus, Syria, retrospectively for about 10 years, and then went cross-sectionally for about 6 months. We used proper sample size calculation criteria for calculating the sample size in both studies. Inclusion criteria where patients more than 10 of age and have a high acquisition quality using the Cyrus built-in Phoenix software. And a comparative patient for a cross-sectional study. We excluded dry eye disease patients, ocular surface diseases, corneal dystrophy, previous ocular scars, and other ectatic diseases other than in one of the eyes, and other corneal scar for any reasons other than keratoconus. Ethical considerations were taken into account, and informed consent were taken from the patients cross-sectionally. We did the investigation using the Cyrus device, which is available in our hospital. The Cyrus used a rotating shine plug camera along with a small angle Placido discs. It gives us a data like topography maps, many data. We use 10 of those maps that the Cyrus device gives us to include in the module that we built. The Cyrus also has a built-in software that gives that use support vector machine, which is a type of artificial intelligence, and also it verifies the or it categorizes the maps for keratoconic or normal or keratoconus suspected patients. It uses other indices like the symmetry index, like best fit radius of anterior corneal surface, and the minimum thickness within 8 millimeters of the map. So the research process where first, after viewing the maps, we took a 9 millimeter radius for most of the maps and 18 millimeter. We used toric ellipsoid reference body. Two independent researchers categorized the data. We also conducted interreliability tests for those researchers. We categorized data into suspected and keratoconic and normal corneas. We then the diagnosis was based on Stinjab reference, which used the anterior sagittal map and the posterior elevation mostly. Then we built a system which is an artificial intelligence-based system using computer vision and deep learning algorithms, 10 input layers and 1 output layer with pooling, flatten, and hidden layer in between. There is L2 regularization and dropout layer. We use 20% of the retrospective data for validation, which like prevent overfitting, like the model learns or memorize the picture, or it's something for prevent bias in the training of the module. For the cross-sectional data, we made a complete eye examination and investigations. Then we the training data set, we categorized it by the researcher, by independent specialist, by the Cyrus software, and the AI. Then we added two groups, like the doctor and the Cyrus software, doctor and the artificial intelligence, with the help of the artificial intelligence. Then we conducted a statistical analysis. As a result, we had 1,943 eyes for the retrospective data. 30% were keratoconic, according it may be to the retrospective nature of the study. Then the testing data were only 3% keratoconic because we took the data cross-sectionally for 422 eyes. We had a very high sensitivity, specificity, and other variables for training, validation, and testing variables, which gives us a very consistent results for the module. Also, the outcome of the testing data were all high sensitivity, specificity, and other statistical analysis. When we took the accuracy, we found that the doctor, with the help of artificial intelligence, had the highest accuracy as a group. So that's a very beautiful result, actually. So we need the doctor and the artificial intelligence together to categorize the patient. It was the best. It also, when we compared it with the McNamara test between doctor and with the help of artificial intelligence, was better. Our system was better than the system built in this the Cyrus software. When we used the map, only one map, we found that the tangential anterior map gives us alone, without other maps, the highest accuracy for diagnosis of the keratoconus. Compared to previous studies done before our study, we had one of the lowest actually diagnosis and accuracy, but we have a very high sample size compared to other studies. We also have real patients without computer-generated maps like we found in other studies. Finally, KeratoDetect application that we named it as an application uses national data to categorize the keratoconus, and it's available on local server. Thank you so much.